The next session is what we all direly need on the day of exam, the do's and the don'ts. An eminent professor who is the Dronacharya in the field of pediatric medicine and gastroenterology. The first gastroenterologist from ICH who also established the department and now currently a consultant at KKCTH. He is the examiner for MD and DNB exams throughout the country. We take a great pleasure in welcoming Professor Dr. Sankaran Narayanan sir.
There are two groups of students available. How many are DNBs? Sizable. So DNB cases are semi-long cases. MDs are long cases. MD, they expect you to go in depth, and the time limit is probably 1 hour for each case. Whereas DNBs, it is only 40 minutes. So whenever you approach a child, you arrange your timings accordingly. That is something basic. When you want to build a house, you need a plan. If there is no plan sanction, it is invalid. So this is what we wanted to just say. What is that? Next one has come. If you are going to have 40 minutes, I thought history taking, you should allot 15 minutes. Examination, another 15 minutes. Another last 10 minutes, you organize your thoughts. What is the history diagnosis? What is the physical examination diagnosis? What is the provisional diagnosis? How did you make a diagnosis? In each case in the exam hall, this child will come with at least 1 or 2 predominant symptoms that you need to know. The most important mistake that they do in the exam is the child may be having probably a cerebral palsy or liver or something. But the child might have been admitted for a minor illness, maybe for a dengue or a diarrhea. The candidate will concentrate for 15 minutes on the incidental finding and describe, and finally missing the case you are supposed to discuss. So best is to see whether the patient is an inpatient or an outpatient. If the patient is an outpatient, most likely they are all coming straight after letter or phone up and then for exam. If the patient is an inpatient, there are 3 or 4 reasons why the child is an inpatient. It may be admitted for an exam sake. It may be admitted for a minor illness. It may be admitted for a therapeutic procedure intervention. It may be admitted probably for postponing follow-up and then doing some investigation and sending. So try to find out whether inpatient or outpatient is question number 1. Then of course, this 10 minutes that you are going to allot is always, what's your history diagnosis at the end? What is your provisional diagnosis? Is it single or more than one? You need not give half a dozen differential diagnoses. You will never come to a conclusion. There is no purpose of exam. So you need to go for at least 2 or 3 maximum differential diagnoses, and it should be always allied. The most important thing as a clinician, I always insist, it is not the predominant symptom and system, but what are the comorbidities that you come across in that child. I will give you an example. You have a child with VSD. You take a history of left-right shunt. Fine. But VSD need not be always isolated. Most often it may be syndromic. Don't miss the syndrome. So basically this particular child is syndromic with probably a dysmorphism, and then the child is manifesting. That is how you need to guard yourself. Approach a child with the background of the child. This is what we call it as candidate diagnosis, candidate history, candidate physical finding. Like that you need to organize your thoughts and then go ahead like that. Whenever you go at the end of your physical examination, history, provisional diagnosis, differential diagnosis, and your plan of thoughts, what are you going to do next? Clinically, anything are you missing? Positive findings, negative findings in a given case. What is needed then is, when you approach the child, sir, can I start? Then you go on looking at the child's face. Never again go on seeing the baby and go ahead in your presentation. Once you finish, that means if you are very clearer, there is no need to see the patient again unless the examiner asks you. This is a very bad mistake. You go on looking and trying to find something new, you will automatically develop a thought block. So this exam flow has to be there. That is what is most important in these people. And never allow the examiner to ask any question, and you are supposed to continue, discuss history diagnosis, predominant two symptoms evaluation if there is there, and second, what is common? Parvati means girl. Parvati cannot be a boy. You don't bring in this type of intersex differences in the exam hall. You will invariably create a unhealthy atmosphere. That is what I wanted to tell you. Step by step. This is what I finished now. Take two predominant symptoms, evaluate. Complications and comorbidities should not be forgotten. History diagnosis, one or two differentials. Which system? That is very important. Usually multiple systems are not kept in the exam. Acute or chronic. Acute cases not usually kept. Chronic or recurrent, of course. Progressive or like that. This gives you the course of the illness there. For any child, there is always an onset. There is a prodrome and there is a course, and then there is an outcome. This is what you need to describe. Pedigree chart. I have seen these people, a child of 10 years coming with a global developmental delay. As the child develops symptoms from birth, I will start from antenatal history. This is what people start telling. I will always say, why antenatal history? You start from love story. When did they start loving? How did it happen? You will never come to a conclusion. Right? Anyhow, you are going to say a natal, neonatal, perinatal, all those things. And you know, always, this fellow who comes with a global developmental delay, hypoxic ischemic encephalopathy, is always a perinatal injury. And why do you want to go? And at the end of spending 10 minutes of that 40 minutes, you will say, the examiner will ask you, will this antenatal history help you anyway? No, sir. Always positive approach for the candidate is very, very important. Whoever teaches, don't worry. In the exam, take it for granted that you have to modify your lifestyle, approach to clear it clearly. You have to do this job. Anthropometry and interpretation is very, very important. I have seen people height, weight, but you are not able to interpret it. Interpretation does not mean answer to the question or telling to the examiner. You have to show to the examiner, unless I am very sure most of you would not have practiced a growth chart as you do this job. Growth chart is part of your OP diagnosis. There itself you need to make a diagnosis. The fellow is undernourished, the fellow is overweighted, the fellow is short stature, the fellow is anything is different, anything syndromic, all those things must be able to put it. Otherwise the examiner will ask you, come on, give me the growth chart. He will ask you. Practice, practice, practice. Growth chart maintenance, how to draw the growth chart, how to maintain it, how to interpret it is part of your pediatric job. Adult, they don't do. Of course, you need not do everything what is given there. I have seen people going on for so many things, but there is no need. But basically, weight, height, and of course, head circumference less than 2 years. BMI, as an examiner, I am not at all very particular if the child is doing a normal weight. If the child is an overweighted, yes. Syndromic, yes. Otherwise, it need not be done as a routine for everybody. Then plot on age and sex appropriate centile charts. What chart at what age? How to do? If you are not practiced, start practicing in future. Common omission that I have observed: insufficient details in the history. The child comes with a fever. You don't describe all about the fever, but you always start talking about the associated symptom and start telling no history, no history, no history, no history, no history. The examiner is fed up and say, at least tell me one positive history. These are all, you are not exam oriented. Knowledge is different, but the exam orientation is entirely different. And DNB exam is all the more different. We are very particular about detailed history. Accepting the child's parents' terminology without question. They will say, I have heartburns. I have heartburns for a older child. Somebody will come and say, I have appendicitis. Everybody will come and say with the diagnosis, because most of the people might have been seen by so many doctors, they might have given a provisional diagnosis and they carry it on to you. So you need to put lot of question. Then leading question is only for an undergraduate. For a postgraduate, you are going to be a consultant tomorrow. You can always find out, put a leading question. And if the patient is going on telling story, stop it initially, otherwise you are wasting time. I have seen people, this particular child was seen in that particular hospital, waiting for half an hour for the consultant. And then this junior doctor saw, and then they gave a blood test, and then they went by auto, and then they go. Big story, terrific. 90% of the candidates go only with storytelling. You should avoid storytelling, you will never come to a conclusion. Always try to find out the salient two predominant symptom of that particular system for which you need to evaluate. You will get a immediate. Drug history and side effects as a routine, many of you are not doing as a routine. There is no teaching, we are also not doing. This should be written first on the top of the case sheet, then only the name of the patient. Otherwise you will lose the patient. If you write the drug which the child are not supposed to experience again. Who administers the drug and how device? A little too much, but I am happy that if you mention at least the drug allergy. Routine BP on the right arm is a must. Always your one eye on informant and the other eye on the patient is a must. Usually in the exam or anywhere, there may be more than two informants. I have seen everybody giving informant reliable. Without knowing the informant, without knowing whether they are literate or illiterate, without knowing the details, the person who is going to give the details is supposed to be the grandmother, and the mother might have been rearing the child, and finally at the end they will say, sir, it was the grandmother alone was there, she does not know. At the end they will say, by committing all mistakes. The informant is the column to be filled up at the end and not in the beginning. Unless you know, why do you give a certificate that their informant is reliable? This is what is going on. Of course, the one eye should be on the patient, one eye should be on the informant. Wherever the child is above 5 years of age, this is called cognizable age. The child knows what is right and wrong. It is better, you can always tell the mother, whatever the child leaves, I will find out from you. You keep quiet, give freedom for your child to give answer, so that any pain, any other events, the child is the better judge to give the complaint. Allow the child to give a complaint. I have seen 11-year child, 14-year adolescent, but the mother will be telling so many things and you will be listening and taking the history. The most important defect in a candidate in the exam hall is they are behaving like a stenographer. They don't behave like a clinician. What they do, the moment that you start asking, Mr. X, Mr. X, age, everything has been going on written, nothing is analyzed, nothing is evaluated. This is what you should not do. Listen to the people. evaluate the symptom and tell this to the people again whether you have missed anything. Reassure, reconsider what you have taken history, and then try to remember your one brain is giving instruction, the other half of the brain is reacting. Use it properly. Then taking history for behavior, dysmorphism, ADHD, any squint from birth, any special phases, etc. should be seen, should be observed by the other eye. Am I boring you? Can I continue? If you are bored, please tell me. Some of these things can be registered, that gives you the lead for examination of the system. Then, say for example, what is the posture? There are actually 3 types of posture, right? As soon as the child comes, what is it that you are going to ask? Whether the child is alert, whether the child is ambulant or bedridden. If the child is bedridden, what is the posture? 3 postures. Usually in the exam, decorticate, decerebrate or opistotonic. Only there are 3 postures. See whether there are any obvious contractions. All bedridden patients, remember that classical, typical 4 B's. What are the 4 B's that you look for in a bedridden patient? Sorry. Bed sores, bowel, bladder, base of the lung. The last but not least is the behavior. So 5 B's you should always remember in all recommend position of these babies. Then of course the nutrition of the child has to be observed and taken care of. The common mistake in taking the height, child can have your socks but not the shoe. And then 4 areas should touch the wall. Occiput, scapulae, gluteus, heel. And then I have seen always the tall examiner is at the top of the roof, the child is at the floor and he is recording it. That should not be there. You have to sit parallelly like that and then keep it. And then go on doing it with your nervous, adrenaline secreted hand. In the exam, you should be in a position to chart and of course find out the differential diagnosis given, be thorough with all those things, at least 5 conditions. Of course, this will give you an idea. Most of the books describe endocrine, systemic, nutritional, constitutional, precocious to be charted out in the growth chart. History taking frequently as to topics as far as the gastroenterology is concerned, pain abdomen, chronic diarrhea, upper GI bleed, cough with expectation, these are all combinations you can have, fits, then sudden loss of consciousness, anemia, autism, of course floppy infant, suspected congenital heart disease or rheumatic heart disease. I'll give you an example. This is the way that you should practice when you go to an exam. If the child comes with a chronic abdominal pain, what is it that you take a history? 10 points for every symptom, at least 6 points you try to make. Duration of pain, site of pain, extent of pain, radiation of pain, severity of pain, character of pain, what is going to be, whether it is really coming under the category of an organic, that means red flags, anything there, or psychological or functional, or combination. Then what precipitates, what relieves. Its relation to 2 things. There are actually 3 things that you notice when you take abdominal pain history. One is top, that is for migraine. Second, abdominal pain regarding the characters, type of pain. Third, bottom, that is constipation. If you are able to take history relating to these three, after the 8th point, not the first point, then you are thorough. Then of course its relation to diet, then its relation to physical habits. What history will tell you that there is a red flag sign or not? Why do you want to know about red flag sign in pain abdomen? Because of organic nature. 10% of abdominal pain will be only organic. 15% may be psychological. The other 75 to 85 goes under the category functional abdominal pain in pediatric. So what tells you that it is likely to be red flags? Red flags is sleep awakening pain. I have seen people describing nocturnal pain. Nocturnal pain is not sleep awakening. Nocturnal pain, the child doesn't sleep at all and they get the pain. But sleep awakening pain is the child goes to sleep, gets up with pain during deep sleep. That shows that it is likely to be most often organic, sometimes functional, never psychological. The second, copious bilious vomiting, GI bleed, marked anemia, severe diarrhea. Loss of weight is not voluntary, it is involuntary weight loss. Then goes for persistent fever, significant posturing of the child due to pain constantly. And these are some of these things will definitely tell you it is likely to be an organic cause for pain. That means most likely surgical. 99% this type of cases will not be kept for you in the exam because you are a pediatrician. But you need to rule out organic cause for these children, right? On examination, palpation of the chest in respiratory system, palpation of abdomen, muscular system, sensory, autonomic nervous system, ENT, preschool, school child, lower motor neuron system, then of course cerebellar demonstration, palpation of lymph nodes, physical examination, demo of rheumatic heart disease, hepatic encephalopathy, bacterial endocarditis, so many things are there. You know very well how to prepare. So what I would advise you, you take long cases, a list of things what are commonly asked in the exam and try to prepare accordingly. This is what is called exam preparation. Knowledge is different, exam preparation is absolutely different. Video stations, particularly for DNBs, Govers and facial palsy, cranial nerve palsy 346, stammering speech, myoclonic jerk, infantile spasm, Maro, ATNR, stepping, thyroglossal cysts, then of course acidotic breathing, fasciculation, pith frog position in SMA, choreoacetoid movement, corpopedal, then strider, nystagmus, so many things are there. Sometimes they may even different types of gait can be shown as a thing. So in OSCE, it is not the diagnosis that is important. The collateral questions, half a dozen questions, you need to answer in detail. Counseling, this is a very important thing, both for MD as well as for National Board people. HBsAg positive antenatal mother, how do you counsel? HIV, thalassemia, baby less than 3 months of age diagnosed with congenital heart disease, ALL, ambiguous genitalia, then undescended testes, recurrent V's, extrahepatic biliary atresia or neonatal jaundice, of course CP with MR, neurodevelopmental delay, floppies, and of course chromosomal anomalies, Downs, on ADHD, autism, inherited metabolic, and picky eater, chronic habitual constipation, so many things. So if you are able to prepare accordingly, I think you may be at it. Some of the procedures, particularly for National Board people, intramuscular injection, bone marrow aspiration, lumbar puncture, abdominal diagnosis and therapeutic paracentesis, endotracheal tube intubation. Of course, less frequently intraosseous subdural tap, suprapubic aspiration, intercostal drainage, peritoneal dialysis, umbilical vein catheterization, ventricular tap, liver biopsy, rectal biopsy, pleural aspirate, etc. So these are all at least 6. If you prepared 10 points, I think this one station you will get at least 8 marks out of 150. Observed counseling is one of these things very important. An adolescent girl presents with HBsAg positivity, how will you approach? You need to know. For want of time, I may not be able to go, but I will give you the questions. You prepare it accordingly. Inspection of the abdomen. Last time I prepared the question. Inspection of the abdomen, palpation of the abdomen are routinely said, routinely practiced. But what we are interested in knowing in OSCE, if you are going to see something, you are supposed to know why you see. That's a very, very important thing. This is what the model hereafter. Inspection of the abdomen, give commentary about what you look and explain why clinical significance of your looking in a 10-year-old boy. This is what is more important. You will say scar. Yes? Agreed? For an MD. For a national board, we don't agree. We will say, what type of scar? What does it indicate? Can you get any clue from the surgery being done? Are you able to identify the underlying condition for which the surgery was done by looking at the nature of the scar? This is training. Learn it in practice. That's very important. Read all those things. This is what I told you. There are 10 scars. Each one indicate one condition. Different names are given, not very particular. It's enough if you know the size of the scar, the type of the scar, the site of the scar, you can make a diagnosis. For example, coccus incision, biliary surgery, probably. That's what it is. Say, for example, if the child has got a infantile hypertrophic hallucinosis, there will be a epigastric paramedian horizontal scar, little about 3 centimeters. That's all. You make a diagnosis. I will go to palpation of the liver. It's a common thing. There's a difference between people who go for MD and national board. For palpation of the liver, we are very particular that whether you test whether you have read clinical methods. At least 6 books are available for clinical methods and only 2 are recognized. I have seen people reading short books, notes, and coming and doing mistakes in the exam hall. Never practice like that. We are going to revise that book. Recently, we have taken the responsibility. A lot of mistakes. None of the examiners agree. So better you read Piyush Gupta or Hutchinson Hunter. The difference between the two, Piyush Gupta is meant for pediatrics. Hutchinson Hunter is meant for pediatrics and geriatrics. A lot of things are given for that. If you take palpation of the liver, you check. He says cupping method first for palpation of the liver. And that is meant for an alcoholic liver disease. So you have to choose what to look for, which book to read, what to practice. This will be, you have to use it properly in your preparation. Palpation starts from left iliac fossa and ends with scrotum. That is how you need to know. 10 points for palpation of the liver. Read. Splenic palpation. Yes. Organomegaly. I have seen how do you grade the splenomegaly. People will say medial to the midline, up to the midline, crossing the midline. Mild, moderate, severe. Which book says? Who agrees? Your fate is decided that you have not touched the book. You need to read. less than 3, 3 plus to 7, 7 plus centimeter. And then bimanual palpation. Never start always from right iliac fossa if there is no complaint. If the complaint, if the underlying situation, context is relating, then you go from right iliac fossa. A minimally palpable spleen need not be examined from right iliac fossa. You can go straight to the left hypochondrium and examine. I have seen people, what is the size of the spleen? 3 centimeters. Sir. Does it come under mild or moderate or severe? Massive. Mild. Sir. Why do you say it is spleen? So notch. For a 3 centimeter, you will never feel a notch. Certain things I always repeatedly tell, Parvati means girl. Parvati cannot be a boy. Nobody is happy. You need to know that 3 plus only you may be able to feel this notch. Same thing, liver. Liver, how much it is? Sir, 2 to 3 centimeter. Where? Right midclavicular area. Give me details. Sir, round edge, sir. Firm liver, sir. Then smooth surface, sir. Total imagination. That means you are never examined. For a minimally palpable liver, you just say it is soft, just felt. Or firm, like that. Same thing again. All firm livers are sharp edge. You don't get a round edged liver with sharp edge. Second, you can say irregular edge if it is a cirrhotic. And the most important thing, always give 2 findings for hepatomegaly or liver palpability. One, right midclavicular line, second in the midline. Why? Right midclavicular line, the liver may be small or not palpable. In the midline, the liver may be palpable. Midline liver indicates caudate lobe hypertrophy. It is one of the clinical indicators of chronic liver disease. These are all practical things. That's what is more important for these people. Of course, examination of the liver should go along with respiration. I have seen people poking like that and then try to produce. Then you should be always gentle and of course go along with the lateral border of the index finger, move along whenever there is expiration, you try to move. During inspiration, you try to palpate the liver. This is what very important. Same thing holds good for hepatomegaly. Extent of hepatomegaly also 3 centimeter, 3 plus to 7 and more than 7. And we normally ask common questions. What are the common causes for massive splenomegaly in pediatric age group? Isolated splenomegaly. The first question comes is chronic malaria. We know that you are read a short unrecognized book. Malaria, all of you might have spent 2 to 3 years in your practice of pediatrics. How many cases you have treated as chronic malaria? How many cases CSE? That means you are challenging the program. National Malaria Eradication Program has been doing very well. I have not seen chronic malaria or the so-called tropical splenomegaly for the last 20 years. And the School of Tropical Medicine from Calcutta authoritatively gives everywhere the talk, never mention about tropical splenomegaly or chronic malaria as a first diagnosis or second diagnosis. It should go at the bottom. So please don't mention tropical splenomegaly and that. Same thing holds good for alpha-1 antitrypsin. Alpha-1 antitrypsin deficiency is not seen in India because the allele is not there. Never bring certain wrong things, never have wrong ideas when you go to an exam. You must be clearer. The next one, of course, is for that is the massive splenomegaly. 4 conditions: extrahepatic portal hypertension with hypersplenism, Gaucher, infantile. Then, of course, hemolytic, particularly thalassemia major. Moderate with chronic, you can have spherocytosis. North, Kala-Azar. These are the four first you should think. Second, less commonly, myelofibrosis, chronic myeloid leukemia, any hypersplenism. What about massive hepatomegaly? Isolated. The most common massive hepatomegaly that you see right from birth, biliary atresia. Little older child, choledochal cyst. Congenital hepatic fibrosis. Sometimes, most often, you get the big isolated liver, glycogen storage disease type 1. Fatty acid oxidation defect, you can bring it as a differential diagnosis. Then comes the congestive liver if the child is above 6 to 8 years of age. These are the common causes for isolated. Massive liver and spleen without any liver disease. The most commonly that you see biggest is mucopolysaccharidosis. You don't do any investigation. Lymphoreticular malignancy, histiocytosis, torch infections, congenital tuberculosis. These are the things that you normally bring in for common things. So read whatever that we say and vomit in the exam. Try to read unnecessary things, of course. Right. Ascites. Yes, commonly people do not know what to look for. What is the gold standard clinical sign of ascites? Anybody? If it is not there, there is no ascites. See the silence. We are not prepared. The gold standard clinical sign of ascites is flank fullness. We will all look at the abdomen. We will say umbilical hernia, inguinal hernia. That comes only long-standing, moderate to massive refractory ascites. How do you grade? Mild, moderate, severe. Mild, Pudelstein positivity. Moderate, shifting dullness. Massive, fluid thrill. All cases of chronic liver disease will present 100% presentation abdominal distension. So you try to give details about abdominal distension. You have won the race. Second, presenting symptom. It may be jaundice, it may be constipation, it may be bleed. Then evaluate that. Your job is over in the history. You make a diagnosis. The second thing, of course, in the ascites, what you see. If the baby is 3 months, how will you do Pudelstein? Standard question. Baby is 8 months, how will you do Pudelstein? You can't make a child on knee chest position. Anybody? See how difficult it is. This is what we normally ask in the exam. Practical. Exam oriented. What you do is make the child face down, ask the mother to one hand on the thigh, another on the chest, let them keep the child like that. This is what is called charity position. Then start doing it. This you should know for a very young infant, charity position you need to do about that. Of course, all children with abdominal distension, don't forget, invariably there is what is called swelling on swelling in the history. Abdominal distension invariably will be diffuse. Then you look for flank fullness. Then swelling on swelling, umbilical hernia, cavernous hematoma. Then of course divarication recti, inguinal hernia, inguinoscrotal ascites. This is what we call it as swelling on swelling. People are fond of telling in the exam, smiling umbilicus. Who is smiling? If the examiner asks you, you will get a sorry figure. Smiling umbilicus occurs on top of edematous bowel wall. You will not get smiling umbilicus without very severe hypoproteinemia. Leg is swollen, scrotum is swollen, abdomen is swollen. So in all cases of ascites, there is not only ascites, you have a clinician's mind to see whether the child has got a edema also. That tells you child has got the albumin is less than 2.8. So how do you know the child has got edema of the abdominal wall? Pressure effect. Tight clothes, ring, coin, button, pressure, everything will give you the thumb impression. That tells you that there is edema plus ascites. So what happens if the edema is persisting, little more gross, this umbilicus is buried. So the circular margin of the umbilicus is buried and the organomegaly comes and then this goes, get a transverse slit, looks like a lid. This you call it as smiling umbilicus. Otherwise, never try to bring in. Always in the exam, omission is better appreciated than commission. Never volunteer and tell all those things in these people. Right. Am I boring you? Is it okay? Are we learning anything? Please ensure. Adal sollungamma. Right. Do's and don'ts. Inspection includes what and why you look for always. One eye on the patient, another eye on the informant. Informant has to be filled up at the end, not at the beginning. Sit parallelly and observe movements of the abdomen. Distension, always think whether it is a fluid or an organomegaly. How do you know from the history that the abdominal distension is due to the fluid? Certain clues are there. A fellow is already a chronic liver disease. Salt restricted diet. A morning pill, forced diuresis. Abdomen is uniformly distended. Flanks are full. Swelling on swelling. Past history of tapping. What else you need? Say it is that. Umbilicus usually in the midline, neither goes up nor comes down. If it goes up, ovarian. If it comes down, probably organomegaly. But that does not happen when there is a massive ascites. When the ascites comes massive, the liver shrinks. Spleen comes out. Splenomegaly, chronic, in extrahepatic portal hypertension or anything, usually doesn't come. Mother will say that particular child has got some heaviness on the left upper quadrant. That is all because of the pulling of the ligaments. Any scar, I told you already, palpate the left iliac fossa and then go in an anti-clockwise in the exam, in stepwise order, spleen and then right loin, etc. No poking. Oh, sorry. Midnight preparation. Right. The poking. Right. Then exactly measure the extent of palpability and then right midclavicular line and midline. I told you left lobe enlargement indicates chronic liver disease. Also palpate the standing posture for hernial orifice. Don't miss vaginal, synechiae and phimosis and of course descent of testes in these people. I have seen people who don't examine the testes but they say it has not descended. But the examiner finds out, you get a sorry figure always there. Again, that's a mistake, sorry, probably I copied from there. Move lateral border of index finger parallel to the liver. Exactly measure the palpability in it is a repetition, sorry. How do you take history? Two symptoms I thought I will discuss with you. This is how you need to prepare in the exam. How do you take history for a jaundice? You give all findings in a random. Sometimes you may miss the important thing. Supera kalyana nadandhudu. That type of marriage I never visited. There is only one mistake. What is that? He failed to tie the knot. He failed to. Like that, history, at the end, you must be able to define what is the diagnosis, what are the complications, what are the comorbidities, what is the course of illness. Is it going to be all right or registered for a long contract or poor prognosis? All these things should be gathered whenever you take, not only for this, but also for any disease. Time? Well, I am almost coming to the end. Take how many episodes? Onset, duration, severity, cholestatic or not, complication, treatment, sequelae, follow-up, in between what goes on. So at the end of this tabular column, you know whether the patient gives history of recurrent or single jaundice episode, episodes of jaundice, asymptomatic or symptomatic, of course, whether they are similar in onset, chronic or acute on chronic, improving, persistent, or any other complication you need to make mention. Liver, abdominal distension, I have already told you how to evaluate. Liver, span you need to know. This I don't think that it's needed for you. This needle, don't think that it is only for one condition. This can be used for lymph node biopsy, renal biopsy, etc. This is true cut needle. These are some of these classical cases which you come across in the exam. What is this in an ascites? What do you see? Anybody make a diagnosis? This is umbilical cavernoma. This has to be differentiated from umbilical hernia. Umbilical cavernoma, blue skin. Umbilical hernia, normal skin. Umbilical hernia, reducibility with gurgling. This is moldable. Then of course, this refills. Of course, this has connection with the epigastric and subumbilical veins. There is nothing of that sort there. The expansal impulse on coughing is the gold standard physical finding of umbilical hernia or any hernia. Chronic liver disease, don't forget to look for muscle wasting, also called sarcopenia. Growth failure, edema, ascites, of course, jaundice of more than 3 months in children. Of course, it may last for more than 6 months also, beyond that. Heart, enlarged left lobe of the liver, forms splenomegaly. These are some of the peripheral markers you should look for. Xanthoma, gynecomastia. Never say spider nevi. Any child less than 10 years, we don't see spider nevi. Very, very rare. KF ring, any hepatomegaly, splenomegaly above 4 years of age. This is a clue for cherry red spot. You just for cherry tree never grow. I will come to the last. This is the last one I thought I will share with you. Allegedly, consequences of portal hypertrophy. Cholestasis you need to mention in the exam. Biliary atresia is commonly kept. How do you describe these phases? Everybody will say coarse phases. Coarse phases even I have. This is called grotesque phases. Grotesque phases, if you mean hurler. I will give you the last one for want of time. I am rushing it up. If you really want to pass an exam, prepare sincerely. Never take a chance. To accomplish great goals, you have to react positively. Never dream, but also dream. But not plan, but always believe in doing whatever you see real justification. Of course, best wishes. What one needs if you really want to be a topper, whatever we teach you, you receive it first. Then register it, recollect it, remember it, reorient it, try to reproduce mentally and verbally, of course in action also like me. Repeat till the end, be a topper. Thank you.